Good afternoon, everyone. My name is Sarah Fuchs, and I am a senior specialist with MDA. We're glad to have you join us for our MG virtual learning series today. This learning event is a part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to our website for on-demand viewing at a later date. Please know that all phone lines have been muted, but you can still ask questions. We'll have a Q&A session at the end of the webinar with today's presenter. Simply use the chat feature to type in your questions, and they'll be addressed after the presentation. MDA would like to thank our sponsors, Alexion, argenx, Genentech, and UCB for supporting today's virtual learning series. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, care, advocacy, and engagement. Excuse me. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research, with $57 million invested specifically in myasthenia gravis. MDA funds projects throughout the drug development process, from early discovery through translational stages and infrastructure support for clinical trials. MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy network focuses on support for accelerated approvals and novel research, access to healthcare, treatments, independent living, newborn screening, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. In 2023, we offered over 40 educational programs, over 20 summer camps, and dozens of other community-based activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free. Please see the link in the chat to learn more about that. And you can also learn more by visiting mda.org. We'd like to recognize that June is MG Awareness Month. MDA is dedicated to supporting the MG community. Over the last 7 decades, MDA has invested $57 million in research for MG. We invite you to check out MDA's resources for MG listed on this page. To learn more about MDA's efforts in MG, please visit mda.org. MDA is excited to bring you this great lineup of presenters over the next few days who will be here to give us up-to-date information on myasthenia gravis. First, we will hear from Dr. Srikanth Muppidi regarding advances in research and care for MG. After the opening presentation, we will also have a drug development roundtable with representatives from our program supporters, Alexion, argenx, and UCB. Later, Dr. Claire Spahn will be here to discuss medication management with MG. Looking ahead to tomorrow, we will have 2 more presentations. Dr. Leslie Delfiner will be here to discuss considerations for children with MG, and we will round out our series with Dr. Jeffrey Rosenfeld, who will discuss treatment management to alleviate symptoms of MG. We encourage you to attend both days of presentations so that you can receive this great information and ask our presenters your questions. Now it is my pleasure to introduce our first speaker, Dr. Muppidi. Dr. Muppidi is a clinical professor in the autonomic and neuromuscular divisions. After finishing medical school in South India, he obtained MRCP in London before moving to the US. Dr. Muppidi completed his neurology residency training at Thomas Jefferson University and his neuromuscular fellowship at UT Southwestern Medical Center. He specializes in clinical care and diagnostic testing for various autonomic disorders and neuromuscular disorders. His clinical interests include various types of neuropathies, autonomic disorders, and myasthenia gravis. His research interests include treatment and outcome measures in myasthenia gravis, methods to detect autonomic impairment in diabetes, and diagnosis of and management of immune and neurodegenerative causes of autonomic failure. I apologize. Dr. Muppidi, thank you for being here today. I'll now turn the time over to you.
Thank you so much, Sarah, for the invitation and the opportunity to present. I will share my screen. Sarah, yeah, perfect. Well, okay.
Perfect.
Thank you so much for all of you for joining this session. It's a privilege to talk to all of you. I've worked with MDA teams, and they have been such an instrumental part of growth of MG Care. And we have a series of lectures. One of my colleagues is going to talk after me, Claire Swan. Even if you lose your attention during my talk, please make sure to listen to her talk later today, because she has a lot of practical clues and pearls that you can use in your own practice, as well as if you're a patient, things to know about various medications. And also you have interesting talks tomorrow, again, talking about sort of care of MG overall, both in children and how to sort of manage long-term care in MG. It's challenging to put everything together in about 30, 40 minutes or so when it comes to research and care of MG. But I've done my best to highlight some of the things. I've noticed that when I talk to patients with myasthenia gravis, there's obviously sort of variation in the level of understanding of the disease. So I'll start out by making sure that we're all on the same page as to what we understand the disease to be. And then from there onwards, I'll talk about some of the newer therapies that have been developed and some of the newer therapies that are in development that are even more potentially promising. Here are some of my disclosures. One thing I wanted to highlight was that I will emphasize when a drug is FDA approved and when the therapies are in development, just so that there is no sort of concern or questions about is that drug available or not at present. Some of the objectives of this session, I will talk about the diagnosis of MG and how we as clinicians diagnose MG currently. I'll talk about some of the traditionally used therapies as well as more recently approved therapies. And then I'll finish up by talking about therapies in development right at the end. There are many phases to myasthenia gravis. No single patient has the same problem. Although typically patients with myasthenia gravis have double vision or weakness of the face, or eyelid drooping, they might have difficulty with speaking or swallowing or chewing. They might have weakness of fatigue, weakness of arm and leg muscles, or difficulty raising their arms, getting up from a chair. But within a single patient, these symptoms can vary from day to day, hour to hour, and between patients, they are quite different. For example, it is somebody with significant eyelid drooping of both eyes, and so having to raise the eyebrows to keep the eyelid up. It is a young woman with a lot of facial weakness and not able to smile completely. Here is a man with what is very obvious, sort of closing of the eyelid, and so he's using his finger to lift his eyelid up. But in addition, this man likely has weakness of his neck, and so he's actually strategically using his hand to keep the head up so that it doesn't fall down. Here is somebody with musk myasthenia, type of myasthenia I'll talk about in a minute, that had gone on for a long period of time with loss of muscle bulk, even in the tongue muscle. So there's a lot of variation in how patients present with myasthenia and the symptoms that they suffer and the challenges that they face. How do we as clinicians diagnose myasthenia? You suspect myasthenia, that's the most important part. I think once you suspect myasthenia, it's not that challenging afterwards with a lot of the testing that is available currently. You suspect myasthenia because somebody have variable or fatigable weakness, or they have double vision, or they have eyelid drooping, or they have weakness that changes from day to day or hour to hour. One can do bedside testing in your physician's office, for example, looking for those fatigable aspects. So if they keep looking up, do the eyelids come down? That'll give you some clues, for example. The most commonly used test is the acetylcholine receptor antibody test. Routinely available, takes about a week, 10 days to come back for most laboratories. If that test is positive, somebody has classical clinical symptoms and examination features, then they have myasthenia. If the acetylcholine receptor antibody is not positive, then we check for MuSK or LRP4. If these are positive and they have classical symptoms, then they have myasthenia. Sometimes we also do additional electrophysiological testing, including something called repetitive stimulation. I'll show you a few waveforms. Rarely we do a test called single fiber EMG. I'll also show you a few waveforms. These also give you additional clues that one has myasthenia. With these series of tests, most of the time we are able to find somebody who has myasthenia. And for example, the single fiber EMG is considered to be the most sensitive test with more than 99% sensitivity for diagnosis of myasthenia. What are the antibody tests that we currently do? So there are a handful of antibody tests that are available. The most common antibody is the acetylcholine receptor antibody. About 80% of the patients have this antibody. There is a second antibody called muscle-specific kinase or MuSK antibody, about 5 to 10%. Much rarer are patients with LRP4 antibody. Rarely we have to rely on a test called cell-based assay. This talk doesn't give me the time to go into that type of assay, but cell-based assays are a finer and more sensitive way of looking at these same antibodies instead of looking them in a test tube, actually looking at the effect of those antibodies on cells and staining them and capturing the results. If one can still have myasthenia even with all of these antibodies negative, and in that case, we call it seronegative myasthenia, as in we don't have a serological marker from the blood of myasthenia. But it doesn't mean that they don't have myasthenia. They still do, but they're called seronegative myasthenia. Our current assumption is that there is still some antibodies that we don't know about, and these patients likely have those antibodies. We know this because even these patients, the seronegative patients, also respond to different autoimmune therapies that I will talk about in a minute. What about the electrophysiology testing or nerve testing? One of the things that happens in myasthenia is the fatigue. And so as you keep doing a certain motion, the muscles get weak. For example, if you keep looking up for a period of time, the eyelids droop. Or if you keep reading, suddenly you start seeing double. So the electrophysiological testing is essentially trying to replicate that fatigue by actually stimulating a nerve. We stimulate different nerves, a nerve in the hand called ulnar nerve, a nerve in the neck called spinal accessory nerve, or facial nerve, a nerve in the face. And what we essentially do is we stimulate the nerve and we record the signals. Here, the height of the signal reflects how well the muscle contracted. And we stimulate the nerve 10 times every time, and then we repeat those 10 cycles. And you will see in a patient with myasthenia, the first response, you get a nice, robust response. But as you keep stimulating the nerve, the muscle gets fatigued because the transmission from the nerve to the muscle is not working well, and you get a much smaller size of the response. This drop from the first one to the fourth or fifth one is what we look at to see if there's a drop in the size of the muscle response after stimulating the nerve. And that's a feature that the nerve muscle or the neuromuscular junction, the point where the nerve communicates with the muscle, is not working well. And that's one of the areas one of the diseases where that is affected is myasthenia. If this is not abnormal, this is normal, then we do another test called single fiber EMG. Little bit more technical study, but simply put, essentially there is a very small fine needle with a small recording area that's inserted into the muscle. And the idea is that we would identify a couple of muscle fibers firing. And when we ask the patient to activate the muscle or you move the muscle, we see that these two muscle fibers are firing. Normally, they would fire in unison as long as there is a signal or a need to activate the muscle. In patients with myasthenia, because the signal from the nerve, this is the nerve and this is the muscle, is not working well, these two fibers don't fire in unison, or sometimes the second fiber doesn't fire at all. And that gives you a sense that this is a neuromuscular junction problem. And that's one other way to diagnose myasthenia, especially if the antibody tests are negative. This is a specialized test, certainly requires a lot of experience of the physician who is doing it. But it's a core test in patients who do not have antibodies currently. There are different types to myasthenia gravis. There are patients who develop early in life, teenage years, 20s, 30s. There are patients who develop late in life, and there are subtle differences as to how we go about treatment, how they recover over a period of time. Patients who only have myasthenia just in the eyes, and we call that ocular myasthenia. I talked about the seronegative myasthenia who don't have any of the antibodies. Patients who have MuSK myasthenia, LRP4 myasthenia. Occasionally, most of the patients, as I said earlier, have AChR antibodies. So there's MuSK and LRP4. And sometimes patients have something called thymoma, which is a tumor of the thymus gland right behind your sternum or your chest bone here. Myasthenia is associated with abnormalities with the thymus gland. Sometimes there is prominence of the thymus gland. Sometimes, rarely, 5-10% of the cases, there might be a tumor of the thymus gland. And those patients have a different course to their myasthenia. Other ways to thinking about myasthenia is not necessarily based on when it started or what antibody do they have, but what other diseases they might have. Because it's a very well-known autoimmune disease, there could be other autoimmune diseases such as lupus or thyroid disease or thyroid eye disease. There might be a history of thymoma, other treatment-induced disorders. So they're on medications such as prednisone that itself can lead to other complications over a period of time, and so on and so forth. So there are few commonly recognized associated disorders that we always look for, looking for thyroid dysfunction, looking to make sure they don't have lupus. So those are common associations. If somebody has myasthenia, we always look for them to make sure that they don't have a underlying other autoimmune disease that's not detected. And I just want to introduce this one metric, and I'm sure Dr. Rosenfeld will talk about this tomorrow, is a scale called MG-ADL, or Myasthenia Gravis Activities of Daily Living. It's a simple questionnaire that captures how patients are doing over a period of time. It's currently used in all clinical trials as the primary clinical trial metric. But additionally, it's easy to do. Patients can even, once you get trained, patients can even do it by themselves. Because it's so easy to do, it can capture patients over a long period of time as to how they are doing in terms of their symptom burden. And there is other reason I'm introducing this is that I will show you some of the treatments that are in development and that have been approved recently. And how they've been approved is because they made a difference to this particular outcome measure in patients. So I want to make sure that we're all on the same page when I mention MG-ADL. What metric am I talking about? So it has 8 questions, and each question is rated from 0 to 3. If you have no symptoms, it's 0. If you have maximal symptoms, that's 3. Takes a few minutes to complete. And so that's the metric. You will see there are 8 questions from top to the bottom. Patients have some questions regarding talking, chewing, swallowing, breathing, sort of muscles in this area. If they're weak, they might be affected. There are muscles of the shoulder girdle or shoulder muscles, so inability to brush teeth or comb hair, or you feel like your shoulder is getting tired quickly. And then there are questions about your legs, like getting up from a chair, for example. Do you have to use your arms to get up, or can you just get up without using your arms? And does it vary from day to day, for example? And the final two questions are what we call ocular or vision related. So do you have double vision, or do you notice any eyelid drooping? And everything, as you will notice, varies from 0 to 3. 0 essentially across the board means no symptoms. 3 is maximal symptoms, and then sort of a spectrum between them. It's not the most perfect score. It doesn't necessarily capture everybody's symptom, but on a scale, most patients are able to capture their symptom burden, and it's an easy metric to do and to follow longitudinally. So with that background, we'll go into therapies of myasthenia gravis. So this is a very nice figure a few years ago, looking at some of the therapy developments over the years. Obviously, 40, 50 years ago, not many therapies. And in 1990s and 2000s, some of these oral immunosuppressive therapies were tested and were thought to be effective. Thymectomy in the last decade. And in the last 3-4 years, there have been at least 5 different drugs approved. And so after this figure was created, there are at least 3 more dots of these dots that have become bold. And so they've been approved. And so it's pretty dramatic. You can see sort of this exponential curve, word that we all learned during the pandemic, sudden growth in the number of options that that's happening in myasthenia as a field for a disease that is relatively rare still. It's really gratifying to see that there are so many options in the pipeline still, hoping that we can make a huge amount of difference for our patients going forward. So whenever we think about any treatment in medicine, it's always important to think about what's causing the disease and then think about treatment based on what's causing the disease. Our ability to make a difference is maximal when the treatment options are based on what's causing the disease and how we are interacting with that pathway of the disease causation. So to make sure we're all on the same page, here is a normal neuromuscular junction. So this is nerve terminal. It's a nerve signals. So signal comes down the nerve, and then that leads to release of this chemical called acetylcholine. Acetylcholine comes down, and this side is the muscle, and binds to the acetylcholine receptor at AChR, binds to the receptor that leads to further signaling down the muscle and causes muscle contraction. This happens billions of the times a day. And obviously, we have no reason to worry about it because this signaling pathway works really well. But in patients with myasthenia, this signaling pathway is interrupted. The signaling pathway is typically interrupted in this area on the muscle side of the which is nerve muscle junction, because there are antibodies that are produced that attack the receptors. So there are antibodies that attack the acetylcholine receptors that can bind or block the receptors. These acetylcholine receptors, these Y-shaped antibody structures, can also lead to something called complement, which is a different set of protein that can deposit itself onto the receptors or onto the membrane, muscle membrane, and cause damage, and then sort of reduce the flow or signaling from the nerve to the muscle. There are other antibodies that I mentioned called the MuSK or LRP4 that attack this area of the MuSK-LRP4 complex, which leads to sort of loss of clustering, a loss of ability to have these receptors all together for an efficient flow. And so that's how the disease is caused. So you would naturally think, okay, well, this makes sense. Well, how do we go about treating this? One, we could do anything and everything that we can to prevent these antibodies from being produced, or reduce the antibody levels, for example. Or 2, we can do something here, prevent the complement from being deposited so that patients don't have the damage that complement causes onto their muscle membrane, and so they don't have as much weakness. A lot of the therapies that I'll talk about sort of think about those principles, reasons why the antibody is produced and what we could do about it. Could we reduce the antibody levels? Could that make a difference? And then can we reduce the complement deposition? And would that make a difference? I realize slightly oversimplified, but it's important to think about these medications as to what they're doing and how we expect a response from them based on what they're doing. So here are all the different therapies sort of summarized quickly until a few years ago, and I haven't included some of the newer ones, which I will in a second. So we talked about one of the reasons the antibody is produced is because of the T cell mediated, the thymus cell mediated B cell, which produces the antibodies, autoimmunity. So, for example, we offer a treatment called thymectomy, which is a surgical procedure, take out the thymus gland. There is a lot of data for this. It's been approved. It's sort of rather tested in a randomized control trial and clearly makes a huge difference to have the thymus out. But predominantly in young people, folks who are below 60, for example. And so that's where this would work. You can have various oral immunosuppressive agents, prednisone, azathioprine, mycophenolate. Those medications would work on the T cell or the B cell and reduce the body's ability to produce these antibodies. We also use things like IVIG or plasma exchange. They would reduce the pathogenic or the antibodies that are causing the disease. Until recently, 4 or 5 years ago, we didn't quite have drugs for preventing complement deposition. We also use a medicine called mestinone or pyridostigmine. And what that does is it increases the amount of acetylcholine at the neuromuscular junction. And some of you might be taking this medicine, frequently used in myasthenia, does help. It's not a cure-all medicine, but it does make a difference. And so it increases the amount of acetylcholine, but it's what we call a symptomatic therapy. So if you have symptoms, it can make a difference, but it's not an immune therapy. These medications that work on this side are considered to be immune therapy. Essentially, what we're trying to do with the immune therapy is to prevent the damage to the neuromuscular junction, especially to the receptors, by reducing the antibody levels, by reducing the complement deposition. And so these are some of the commonly used long-term agents. These are mostly all oral medication. They take a few months to work. And the way they work is by affecting the B cell and T cell function up here. Of course, they affect all B cell, T cell function. They cannot only affect the ones that are producing the antibodies. And then they take a few months to work. So you start the medicine, and the effect really kicks in after a few months. Unfortunately, because they have such a global immune suppressive properties, they have many potential side effects, and one has to be aware of these things and monitor for them, including lab tests. My colleague Claire, who will talk after this session, will go into some of these medications in a bit more detail and best ways to monitor effects of those medicines, side effects, things that one can do to prevent complications. Some of these drugs have been available for a long period of time, but it was gratifying to participate in a study recently called Promise MG, which looked at how medicines like mycophenolate or Cellcept, azathioprine or Imuran, how they work in patients. So this was a multi-centered trial where we recruited patients from our clinic. We would treat them as we would normally treat them and follow them longitudinally. And the main take-home message is that all patients, whether they were on mycophenolate or azathioprine, had some improvement in their clinical symptoms. They were not curative, but these medications do work. They take a while to work. And sometimes that's a challenge. We want something that works immediately. And now we have more options for that. But traditionally, these drugs take a while to work. Other treatment that should be considered in patients with ACHR myasthenia gravis, especially in the younger age group, is a procedure called thymectomy. This is where a surgical procedure is done to take the thymus gland out. If there is a tumor of the thymus, that's what we call thymoma, it should definitely come out. But if you're young and if you have the ACHR antibodies, there is a lot of data from the clinical trial that doing the thymectomy will reduce the amount of prednisone or steroids you require and lower the need for steroids, the better it is because they have many potential side effects and complications. It will also improve your strength if you have had thymectomy compared to those who did not have thymectomy. And we generally advocate for this in our patients and younger patients. Unfortunately, it has not translated to clinical practice as well as we would have liked it to. I think part of the challenges is the surgical procedure. It's not done by your neurologist. It would have to be done by a cardiothoracic surgeon. And most folks might not want a scar right in the middle. It can also be done sort of with less invasive procedure from the side of the chest. And this one of the studies that looked at patients as to why they did not have thymectomy. And the feeling was that the discussion did not happen with their doctor. And I'm hoping, sort of going forward, if any of you feel like you would qualify, you have the ACHR antibody, you're young, I hope you would have a discussion with your doctor about whether you would be a candidate for thymectomy or not. The second thing about thymectomy is that obviously it's a surgical procedure, but the benefit doesn't happen right away. Again, benefit takes many, many months to be effective. But in the clinical trial, we know that those who got the drug clearly had a better response over a period of time. There are newer therapies that are now FDA approved, therapies that we talked about how we can make a difference in this pathway of the disease causation. One is, can we reduce these antibodies, these Y-shaped structures? One way is you can reduce the antibodies is in these newer line therapies called FcRn therapies. They essentially reduce your immunoglobulin levels. And so you reduce your immunoglobulin levels, your antibody levels also go down. Another way is, can you make a difference to the amount of complement that is being deposited? And so there are drugs that reduce the complement deposition, and that also improves symptoms in myasthenia gravis. So first, we'll talk about complement therapies. This is one of the newer therapies, last 4, 5 years, 6 years or so. The very first drug was approved, I believe, in 2017. And then since then, we have 2 other complement therapies that are FDA approved. One key important point is that the antibodies that are typically cause complement activation are the ACHR antibodies. So these are patients who have the ACHR antibodies that have been proven, the complement drugs have been proven to be effective. And the way they work is by the reduced complement deposition. I don't expect you to know. Many of us physicians learn this early in our medical school and promptly forget it after we take a test, because until recently we really didn't have many drugs that would utilize this pathway. The key take-home message is that the complement deposition is critical for the autoimmune diseases, including myasthenia. But it's also important to fight certain infections that can cause things like meningitis. And so with all complement therapies, there are some requirements regarding vaccination and potentially antibiotic therapy. And my colleague Claire will talk a little bit about the importance of these steps in starting complement therapy and the importance of being on top of your vaccination schedule if you're on a complement therapy. So I won't go into it, but I just wanted to emphasize that when we prevent the complement deposition to reduce the symptoms, it's wonderful. These drugs are highly effective, but it's also critical that it reduces your ability to fight certain infections, and we have to do everything we can to prevent those infections from happening. These are the 3 complement therapies that are currently approved: eculizumab or Solaris, ravulizumab or Ultomoris, and zilucoplan or Zilbrysq. Eculizumab and ravulizumab are given intravenously as an IV. It can be given at an infusion center. It can even be given at home. At home, nurse would have to come and give it to you. Eculizumab is given after the initial loading dose, given every 2 weeks. Ravulizumab every 2 months after the initial loading dose. Zilucoplan is subcutaneous. One can give it to themselves easily, and it's done daily. Eculizumab. This was the first complement therapy that was approved. And these are the different outcome measures that we use in clinical trials, some of them in clinical practice. I had pointed out this one outcome measure called MG-ADL, Myasthenia Gravis Activities of Daily Living. What you're seeing here is patients, which is the blue line, and placebo, patients who did not get the drug but were part of the clinical trial and they got placebo, is the red line. And 0 is wherever they start with. And then the x-axis at the bottom is the time as to how they did over a period of time. And you can see soon after starting the drug, within a couple of weeks, the blue line clearly separates itself from the red line. The steeper the drop means the higher the level of improvement, the more symptom improvement. And so you can see across the board with all different outcome measures, there's a clear distinct improvement in the blue line, which is the eculizumab group, compared to the placebo group. Another important way of looking at data in myasthenic literature is these Christmas tree plots, we call them, where on one side, again, the blue is drug, red is placebo, and then what you're seeing on the y-axis is different levels of improvement. Higher the number means greater the amount of improvement. You will see across the board more patients on the blue side compared to the placebo. And especially when you go to higher levels of improvement, a lot more patients fall on the ones where they got the drug compared to the placebo. Eculizumab clearly makes a difference in the AChR positive patients with myasthenia, clearly leads to improvement in symptoms within few weeks. And when you see them over a period of time, much higher levels of improvement, obviously, compared to placebo. After the initial 6-month randomized trial, which is half got the drug, half got the placebo, we didn't know who got the drug or placebo. We also did an open label extension study, and you will see that here again, blue is drug, red is placebo. Here, when they transition to the open label, everybody gets the drug. You can see the red quickly catches up to the blue. So the moment they are on eculizumab, they quickly catch up to the cohort who were getting the drug before. Beyond improving symptoms, it reduces the likelihood of having an exacerbation, intermittent periods of weakness. It reduces the need for a rescue therapy like a higher dose of prednisone or IVIG. It reduces any likelihood of hospitalization. And so these are also important metrics in practice. And if you're a patient, do you not only not want to feel better, of course you want to feel better, you want to feel stronger, you want to have less symptoms, but you also don't want to go to hospital. You also don't want to have intermittent periods where you feel weak or tired. And it was relatively safe. Other complement therapies that have been developed, including the second drug called ravulizumab. Again, you will see here, blue is drug, red is placebo. Again, there is higher levels of improvement with the blue compared to placebo, or drug compared to placebo. Again, looking at the Christmas tree plot, you will see higher levels of improvement with the ravulizumab group compared to the placebo. Again, it works very similar to eculizumab, but it's given every 2 months. Eculizumab is given every 2 weeks. This is also a monoclonal antibody on C5 in the pathway of the complement that I showed you. And the last drug in the complement therapies that is FDA approved is called zilucoplan. This is a peptide, not a monoclonal antibody. And it's given daily subcutaneously. Patients can give it to themselves. It's very easy to do. Again, you will see here, purple is the drug, green is placebo. And you will see that within 1 to 2 weeks after starting, patients have a clear improvement compared to those who did not get the drug. Looking at the Christmas tree plot, Again, much higher levels of improvement in those who got the drug compared to placebo. All three drugs work on the C5 component, binds to the C5, prevent the complement deposition in AChR positive myasthenia gravis. And so all three drugs have been approved. We'll talk a little bit about the second line of therapy that have FDA approved drugs, including FcRn therapies. These drugs across the board reduce antibody levels or immunoglobulin levels. And since all antibodies are a type of immunoglobulins or IgG immunoglobulins, they reduce the antibody levels as well. And so one of the ways we used to reduce immunoglobulin levels and antibody levels is by this procedure called plasma exchange. Some of you might have heard about it. Some of you might have even have had it. Plasma exchange is a procedure generally done in the hospital, occasionally can be done as an outpatient setting, where we put, we take your blood, filter it back, take out all the immunoglobulins or the antibodies, and give it back to you. And so the idea is that when you go through plasma exchange, your immunoglobulin levels will reduce. And because the antibodies are a type of IgG immunoglobulins, even that will also reduce. But plasma exchange is a surgical procedure, takes many hours. Many patients require a specialized catheter, either in the neck or under the collarbone or in the groin, so that they can have this procedure done. Many places only offer this in the hospital. They don't necessarily offer this as an outpatient. But if there was some kind of treatment or therapy that would achieve this without having to go through all of those procedures, and that would be great. And that's one of the things that these drugs called FcRn drugs do. FcRn is a receptor that binds to the immunoglobulins. Initially, it was discovered in placenta, and it binds to the immunoglobulin from the mother's side and then transfers it to the baby. That's how when a newborn is born, they already have some degree of immunity that's coming from the mother. And so initially, since it was discovered in placenta, it was thought, oh, it's only present in placenta, and that's why the neonatal part of it stuck. But it really has nothing to do with the neonatal. It's present in many, many surfaces, including placenta, your GI system, your lung system. And it's a critical part of recycling of your immunoglobulins, especially the IgG immunoglobulins. And so what happens is that normally the IgG immunoglobulin bind to the Fc receptor and helps it recycle so that the immunoglobulins can stay in your system for a longer period of time. However, if you have FcRn antagonists or medications, they essentially bind to the Fc receptor, FcRn, and when they bind, the immunoglobulin cannot bind. And so the immunoglobulin cannot be recycled. And if it cannot be recycled, the immunoglobulin levels will reduce. And when the immunoglobulin levels reduces, that will lead to reduction in your antibodies, because a lot of the pathogenic antibodies, the antibodies that cause diseases, including all of antibodies that cause myasthenia, are IgG antibodies. So if you reduce the immunoglobulin level, you similarly reduce the antibody level. And if you reduce the antibody level, there should not be less antibody-mediated damage at the muscle, and that leads to improved strength. There are multiple drugs. All of them tend to have subtle variations on how they are given, tend to reduce immunoglobulin levels to the same extent. There are currently 3 drugs that are approved, which fall under the FcRn therapies. Efgartigimod or Vyvgart, Efgartigimod Hytrulo or Vyvgart Hytrulo, which is a subcutaneous form. Efgartigimod is an intravenous form. And the third one is called rozanolixizumab or Rystigio, which is also a subcutaneous form. The efgartigimod IV or subcutaneous ones are given weekly for 4 weeks with a break, and then weekly for 4 weeks. Rozanolixizumab is given weekly for 6 weeks. Subtle differences. All of them are required to be given by a healthcare professional. These are subcutaneous, but it is required that it's given by a healthcare professional. This is subcutaneous, but it's an infusion, so certainly has to be given by a healthcare professional. Some of the data for these studies, for these medications, we talked about the Christmas tree plot earlier, and you will see the same pattern here. Blue is efgartigimod, red is placebo. You will see higher levels of improvement with efgartigimod compared to placebo. You will also notice quite dramatic improvement in symptoms after starting the drug compared to placebo, with a very steep improvement within few weeks. There is also sort of a tendency that there might be some return of the symptoms over a period of time, because the way these drugs work, they don't work forever. The immunoglobulin levels do come back up, because the drug only works for so many weeks. Not that everybody requires more infusions, not everybody does, but the drugs work for a few weeks and the immunoglobulin levels come back, and patients might require more infusions. The same thing with rozanolixizumab, Restygio. Again, very steep decline in symptom scores and improved strength after starting the therapy across all different measures of strength, symptom burden, quality of life, fatigue, muscle weakness. And so it's remarkable. They all seem to make a clear improvement in patients with myasthenia gravis. So just to highlight the things that we talked about among the newer therapies, there are complement therapies. These are the three drugs: eculizumab, ravulizumab, zilucoplan. Given intravenously, eculizumab, ravulizumab, zilucoplan is given subcutaneously with different frequencies. There are other complement therapies that are in pipeline. There is a combination trial looking at pozelimab and cemdisiran. This is a combination drug. This is a monoclonal antibody, and this one reduces complement production in the liver. There's an ongoing phase 3 study looking at patients with both AChR as well as LRP4. There is a newer drug that is being tested, for example, gefrulimab, and this is a subcutaneous drug given under the skin, but given once a week, ongoing phase 3 study. And recently there was an oral drug that also works in the complement pathways that had completed a phase 2 study. So these are in development. I'm optimistic that they will have a successful phase 3 results, and I'm optimistic that they will be available and approved, FDA approved in future. FcRn therapies, the currently approved ones, we talked about it, the efgartigimod, IV or subcutaneous rozanolixizumab. And then there are other therapies that are currently being tested, including nipocalimab and batoclimab. Again, we currently are tested in phase 3 study with different infusion frequencies compared to efgartigimod or rozanolixizumab. I, again, remain optimistic that there will be more options available for our patients with these newer FcRn therapies. Across the board, FcRn therapies seem to reduce immunoglobulin levels and antibody levels. And so there is certainly a sort of optimism that they would have a successful study and have more therapy options for our patients. What about MuSK myasthenia? A lot of what I talked about was AChR myasthenia. MuSK myasthenia is slightly different. The way the disease, the antibodies cause the disease is also slightly different. And the way the antibody causes the disease is that the target is the MuSK LRP4 complex, the antibody, MuSK antibody. And this complex is critical for these AChR receptors to be all together. If they are together, the signal transmission from the nerve to the muscle is much more smoother. And so when they're not together, the signal transmission is impaired. MuSK myasthenia also doesn't have any significant complement deposition. So a lot of the complement therapies that I talked about are not quite approved for MuSK myasthenia, not even tested for that. There are some differences to MuSK myasthenia compared to AChR myasthenia. They can have a little bit more of a rapid progression. They can have a lot more weakness of the face, throat, or respiratory muscles. If it's undetected or untreated, unfortunately, can even lead to loss of muscle bulk, like this young person with atrophy of the tongue muscles. We commonly use rituximab, which I believe is quite effective for myasthenia. Other drugs that can be used are corticosteroids, plasma exchange to reduce the antibody levels. And rozanolixizumab, one of the FcRn therapies, is also approved for myasthenia. Pyridostigmine or mestinon, which we commonly use for AChR patients, may not be as effective. Even though rituximab is quite effective and dramatically sort of improves many patients with myasthenia, it doesn't have the same degree of benefit for AChR myasthenia. Until recently, there have been few attempts to look at rituximab in patients with AChR myasthenia, but it doesn't have the same degree of overwhelmingly positive response. There was one recent trial that I'm really optimistic about and might lead to how we approach disease, where they gave patients a small dose of rituximab, just one dose, 500 milligrams or half a gram. But the key was that this was given pretty early in the disease course. So within few months of the diagnosis that they got this small dose and just one dose. Even though this was so early and even though it was so small, those patients who got this drug had a clear improvement within 4 months after getting the rituximab dose compared to those who did not. It's possible that early treatment with rituximab made a difference. A part of me also wonders, and there is some data for this in complement therapies, for example, that early treatment might give a much more robust response and improvement compared to sort of holding off some of these treatments for later in the disease course. And so while I'm optimistic that this effect is rituximab, a part of me also wonders whether this effect is translatable across other drugs as long as you treat patients early and promptly and appropriately aggressively, would you expect to see a much more dramatic response. There are other B cell therapies. So these are medications, including rituximab, that work on B cells. These are the cells that produce the antibody levels. And one of the drugs is called inebilizumab. It's already approved for other neurological disorders, and there is an ongoing trial called MINT trial. I believe the results might be available or might be released later this year. And so hopefully this might be another option for some patients going forward if we were to have FDA approval for this drug in future. Lastly, I'll finish up by talking about these promising new ways of looking at autoimmune therapies. One of the things that, and a lot of these come from cancer literature, patients that are given different treatments for cancer. One of the treatment is called CAR T therapy. And so CAR T therapy stands for chimeric antigen receptor. T stands for T cells. And so the way it works in cancer, for some of the cancers, these are approved therapies, is that we take patients' blood, we filter out the T cells. These are immune cells. And these immune cells are edited further, and so that they can go back in and they can attack the cancer cells. So after they're identified, they're edited, and they grow into billions of cells. And then they're given back to the patient. When they're given back to the patient, those cells go back and attack the cancer that they have. And so currently these treatments are also being developed for different autoimmune diseases, currently for difficult to control autoimmune diseases. And so there have been at least a couple of different therapies in the pipeline looking at CAR T therapies with different type of receptors, but they target the B cells. Obviously, there's no cancer, so they target the B cells. B cells are the ones which produce the antibodies. There is a small phase 2 trial of 18 patients. It was safe. It did not have any of the bad or severe side effects that sometimes are seen in patients with cancer. There was also one very well-written case report of one patient who had many treatments continued to be quite symptomatic, was using a wheelchair, quite dependent, couldn't really walk independently well, was given the treatment, and within few days had a dramatic improvement in the number of steps that they were able to take, from walking around about 200 steps to up to 800 steps. So pretty dramatic improvement in overall weakness and symptoms, and again was very well tolerated. Obviously, one treatment in one patient doesn't mean it's perfectly effective, but these drugs are being tested in larger groups of patients. And I'm optimistic, because of the way we know these drugs work, that maybe they will lead to a sustained benefit over a longer period of time. And I'm optimistic that we will have that kind of outcome for these therapies, as long as they're safe in patients with myasthenia. And so I'll finish by just going through some of the objectives of what I wanted to talk about. We talked about the diagnosis of MG, how we use different antibody testing, AChR, MuSK, LRP4, seronegative, cell-based assays. We talked about different electrophysiology testing, repetitive stimulation, single fiber EMG, value of these tests in diagnosis. We talked about some of the traditional therapies that have been approved and used, and some of the recently approved therapies. Traditional ones include the pyridostigmine, oral immunosuppressive agents, prednisone, mycophenolate, azathioprine. My colleague Claire, when she talks about it, she'll talk about these drugs, potential side effects from the drugs, and how we monitor these drugs and best ways to take the drugs. We talked about complement therapies. These are newer drugs that prevent complement deposition, but they also have unique side effects that require vaccinations ahead of time to prevent infections. We talked about FcRn therapies. These are drugs that reduce your immunoglobulin levels and therefore reduce your antibody levels. We did not talk a lot about IVIG or plasma exchange. These treatments still play a critical role. They play a critical role if somebody was hospitalized with a myasthenic weakness of any type. We still use it in some patients as an outpatient, but not as much as I used to use 5-6 years ago. And then we talked about some of the therapies in development, both in the complement space, in the FcRn space, in the B cell therapies, and in the newer T cell CAR T therapies. So I will stop there, and then we can take questions and have a roundtable. Thank you so much for this invitation.
Thank you so much, Dr. Muppidi. Give me just a second. I'm going to get my screen up here. Alrighty, and yeah, thank you so much for that informative presentation. I'm going to open it up to questions. Again, if anyone has any questions related to the presentation, feel free to type it into the chat box. The questions I have now are from when everyone registered. So Dr. Muppidi, if you're ready, I'll just start to go through those. Excuse me, you discussed recent advances in treatments. Someone wants to know, how do you access new treatments?
Yeah, great question. I think this is one of the things that the field is trying to make sure that we are equitable and everybody has an opportunity to participate. And so one of the ways, if the places that you're getting your care doesn't have a clinical trial for myasthenia, I would encourage you to go to clinicaltrials.gov, and you can type in myasthenia. That will bring up all the different therapies that are available if you want to participate in the clinical trial. If the drug is FDA approved and if you think you might be a good candidate, that would be something to discuss with your neurologist regarding the symptoms that you are experiencing and what are the current treatments that you're on and what therapies might make a difference to those symptoms. This is where I'm a big advocate for patients' sort of self-awareness of what their symptoms are. Things like MG-ADL, other outcome measures, monitoring them over a period of time makes a huge difference. Because one of the challenges that we have in the field is that and I'll include myself in this, when I see a patient, I only see them for 15, 20, 30 minutes, maybe 1 hour at most. And that's a period of time. And if it's in the morning, they might be doing well. I don't necessarily see them at 6 p.m. at nighttime. And so their disease might vary. And I rely on them to tell me how they feel at different points of the day. And so these scores can also capture that.
Absolutely. Thank you. Next question. How can a person get a diagnosis when seronegative and SFEMG comes back negative or borderline? Clinicians are resistant to diagnose.
Yeah, so that's a challenging question. Currently, we don't have a more sensitive method than single fiber EMG. Rarely, if the clinicians and your doctors feel that this could be myasthenia, occasionally we try a short burst of immune therapy to see if that made a difference. Because autoimmune myasthenia is by definition autoimmune, these bursts of different immune therapies might make a clear difference. And if it does, that would be quite helpful. One caveat is that there is also a disease called congenital myasthenia. And MGA, is actively involved in many congenital neuromuscular disorders. In that myasthenia, it will look like myasthenia. They will have fatigue, they will have eyelid drooping, they'll have weakness, but it's a genetic disorder, not an autoimmune disorder. And so giving them immunosuppressive therapy will not make a difference.
Understood. Thank you. Next question. How is MG related to congenital myasthenia gravis syndrome?
Right. Well, actually, I'm not able to read these questions, but it looks like I can. So that's great. So there is autoimmune myasthenia, which is what I just mentioned. Congenital myasthenia is a genetic syndrome. There's a genetic abnormality. A lot of the times it presents itself with weakness or fatigue very early in age, less than 10 years, for example. Rarely we can see patients who manifest overtly much later in life. And so the way we go about diagnosing the congenital form is that we see a patient, we feel like, oh, there is this weakness that could have myasthenic features. We confirm it. They don't have the antibodies. We confirm it on repetitive stimulation or single fiber EMG. And then the more we talk to them, they say, oh, when I was a kid, I was not super active, but I just thought that's just me. I really did not think much about it. And so there are genetic tests available that can help you with the diagnosis. And there are some treatments that can make a difference. They're not immune therapies, but other treatments that can make you feel stronger, including pyridostigmines.
Thank you. It looks like we have two more questions. So any guidance for agrin positive only MG?
Yeah, I think that's a relatively rare condition among all the different antibodies. And the challenge we have is that none of these therapies are approved for that. But I would put this under the seronegative category currently, or you could say it's seronegative because it's not AChR, mask, or LRP4 positive, but we know that there is an antibody. There are clinical trials ongoing currently to look at seronegative patients with FcRn therapies. So I'm optimistic that in future that will become an option. For example, some of my colleagues have treated patients who are seronegative when we can get an approval with an FcRn therapy with a clear improvement. And so I would approach it as a seronegative and sort of think about what immune therapy might be appropriate, including do these novel therapies. Certainly, FcRn therapies might have a role if the antibody is truly pathogenic.
Thank you. Next question. I was diagnosed with MG and had a thymectomy in 1998. My last EMG was negative for MG, but now I have VCP disease. Any connection?
Oh, very good question. I don't think so. These are not considered to be sort of cousins of the same disease. And VCP, we don't think of it as an autoimmune neuromuscular disease. It is rare to have two rare neuromuscular disorders, but I don't think they're connected.
Thank you. Okay, so I do want to just make sure to move forward. Oh, it looks like, sorry, we did have another question here. Is Vyegart good to help MGMUSK version? It seemed to help drastic in the beginning, but not as severe difference in later infusions. Is it best to continue?
Just to make sure we're all on the same page, Vyvgart is efgartigimod. In the clinical trial, they had few patients who were MuSK antibody in the clinical trial, but it's only approved for AChR positive MG. In principle, can it help? I expect that it would make a difference, but it was not necessarily proven in the clinical trial. Usually in my practice, we use rituximab as a primary agent for patients with MuSK-MG and only use FcRn therapies, those who cannot tolerate or have a problem with getting rituximab. I find that rituximab is definitely a lot more effective.
Thank you. It does look like we had a couple last minute questions, so I'm going to do my best to get to those before our roundtable. You made mention of the CART anti-CD19 therapy. What do you think of the CART anti-CD137 investigational drug?
Oh, I will confess that I'm not well versed with the anti-CD137 drug. I was only sort of involved with the CD19 therapies, but I'll probably have to look it up a little bit. Sorry.
No, that's fine. Thank you. With regards to biologics, like rituximab, is immunogenicity of concern to you?
We haven't had many issues with side effects. Sometimes that's seen with different autoimmune diseases and biologics. Part of the reason is that I use rituximab in MuSK-MG, and patients have such a dramatic response. Occasionally, I only need to give them few doses, and their disease seems to be quite stable. And then I also give them a gram 2 weeks apart, so two doses every 6 months if needed. I tend to do that first two cycles, so about 4 doses in a year. After that, doing further doses based on how they are doing and what their symptoms are. So it hasn't been a major challenge.
Great. And then it looks like we have two more questions. So how do you know which one of these therapies is best for you? Do you recommend multiple meds attacking different aspects of the disease, B cell and complement agent?
Oh, that's a great question. I think so. Currently, we don't know. So let's just say I have myasthenia and I go to my doctor. My doctor can look at my antibodies and say, you have AChR, so there is a complement activation, and complement therapies might be an option. But we don't quite know what drug or combination of drug will have the maximal benefit. Usually, we do use multiple therapies. So a lot of the oral agents that I mentioned, azathioprine, mycophenolate, they work on the B cell, T cell. And so most patients where we get complement therapies, I make sure that they're on an oral agent, if at all possible, so that we have effects beyond the complement level. The specific question was, can you give B cell therapy, very robust, strong B cell suppression, and also give complement therapy? I have not. In clinical trials, when patients were enrolled into complement therapies, naturally they would have to be off the B cell therapies for at least 6 months or longer. The challenge is, could you envision that they might work synergistically as sort of additively? Possible. But there is always this concern about the side effects and the infection risk when you use such two strong different biologic medications. And we don't have a lot of data for that.
Thank you. And then the last question. If someone is seronegative MG, has CVID, has failed every treatment, including Rituxan, and has high complement levels, is on Mistanon and IVIG, why not try CAR T cell therapy or complement therapy? Patient is very symptomatic, on oxygen, and ventilator dependent. Could you get a compassionate use approval of drugs?
So I'll tackle the first question. Could the high serum complement levels have not necessarily correlated with myasthenia and complement deposition? But I certainly agree that if they have myasthenia and if they're refractory, it's a reasonable request to look into complement therapies. I don't know about the CAR T therapy because some of these therapies reduce your immunoglobulin, work on B cells, reduce your immunoglobulins dramatically. If you already have CVID, whether that would be an exclusion criteria, I'm not sure.
Well, understood. Thank you so much. I don't see any more questions. So again, Dr. Muppidi, we sincerely appreciate your time and expertise. Next, we are excited to welcome two experts from industry to join Dr. Muppidi for a discussion around drug development for MG. Dr. Sanjay Rakiti is the Executive Medical Director in Clinical Development and Translational Sciences, Neurology at Alexion. And Kathy Perez is the Head of Global Patient Advocacy and Policy for argenx. Thank you all for being here today. And now I will hand it back to you, Dr. Muppidi.
Great. Okay, I don't see Kathy or Sanjay, but.
So I just started my video, Dr. Muppidi. I hope.
Oh, hi there. How are you? How are you? Good to see you both.
Hi, it's Kathy. Nice to see you.
Oh, nice to see you.
Great
Nice to see you.
presentation. Thank you.
Oh, thank you. Thank you. So I was hoping maybe we can go through some of the questions. That'd be okay?
Sure.
Okay.
Sure, sounds good.
Let's do this. 1 second. So one of the questions was, and this is, always something that I think about in my clinical practice as to how we go about patient care and different therapy options. Maybe I'll start with you, Sanjay, first. How do you see the complement sort of space developing with some of the newer therapies being developed, including the subcutaneous weekly infusion option?
First and foremost, thanks to MDA for this opportunity to join this webinar. And I'm really especially excited to join this roundtable discussion during the MG Awareness Month in June. So it's my pleasure to be able to present on behalf of Alexion. I think, coming to your question, Dr. Muppidi, about the use of complement therapies and the advances there, we at Alexion are definitely excited about the use of complement therapies in addressing myasthenia gravis. With Soliris being approved in 2017, that was one of the first therapies to be approved in MG or generalized myasthenia gravis over a period of 60 years. But we also definitely believe in this aspect of treatment optionality and giving the patients the ability to choose their medication and choose a medication that really fits their lifestyle. And that's what we've been trying to further with our advances in understanding of the complement system, as well as the ability to target the complement system. We have tried to do that by bringing forward now with Ultomiris or ravulizumab, the time that's required between infusions has increased to almost 8 weeks or almost 2 months. Now with subcutaneous administration, we are bringing forth geftolimab, which is targeting the C5 factor, but also provides it specifically developed for subcutaneous administration and may provide the ability for patients to be able to administer it, self-administer it at home, and have potentially a once-a-week administration if the trials are positive and we get the results that we anticipate. So, as you can see, what we're trying to do is provide options to patients that can help them choose a therapy that best suits their needs and can help them with gaining control of the disease, but also gaining control of their disease with an ability to utilize it within their own lifestyle and not just coping with the disease, but really controlling it by choosing the appropriate option.
Yeah, I completely agree with you. From my own clinical practice, once symptoms are well controlled, we all have a higher threshold of therapy burden. I don't mind going anywhere, however frequent, when my symptoms are really severe. But when they are controlled, I would love to have options where I don't have to go somewhere every few weeks or every couple of months when I can give it to myself, have a lot more independence that the improved strength allows me to. So thank you, Sanjay. Question for you, Kathy, and this is, I'm just thinking about, your team being the first one to come up with a drug that's only approved for myasthenia and probably will evolve to be approved for many other diseases in the FcRn space in future. Could you speak to about the challenges of developing a drug for a rare disease like myasthenia and how your team continues to focus on myasthenia going forward?
Absolutely. Thank you. And thank you for the invitation. It's great to be on the panel with Sanjay. I think when you think about just the excitement of uncovering the FcRn pathway and being able to find a compound that could address that, identifying myasthenia gravis as the first indication that we would do that research in, and then getting to the point where we have clinical data that actually shows patients may be able to receive or get to minimal symptom expression. I think Sanjay and I would agree, like that's what you want. You want the best symptom control for an individual patient. And you did a great job of explaining there's differences in everyone's journey with MG, and you have complement more important in some, FcRn may be more important. The most important thing to remember is that MG patients none of them are alike, and all of their journeys are different. And it can be episodic. Different things impact patients, their work schedule, how much time they spend on a computer versus do they drive for a living. All of those things impact patients, and you have to find the right combination, the right rest and treatment for those patients. I think that is very exciting that we've got science to a place where we can do those things for patients and get them to a place potentially where they have an MG-ADL of 0 to 1.
Sure. I agree completely. And this was a question that I was going to ask and that actually came up earlier. And I think this is something that the field is also sort of thinking about critically. Maybe I'll give it to Sanjay and then I'll get back to you, Kathy. How can we get more patients with MG access to the drugs in development, both in terms of sort of giving an opportunity for everybody to participate in a clinical trial? We want a sort of a larger representation because, as you know, in clinical trials, this is not just MG specific across the board. There is some variability in clinical trial participation. And then how do we get folks access to some of these very effective but expensive therapies if they're not in a financially state where they can afford them? So maybe I'll give the tough one to Sanjay, Kathy, and then I'll come back to you.
Thank you, Dr. Muppidi. And again, I agree with most of the things that Kathy has mentioned as well. I think that the ability to have minimal symptom expression or reach a stage where the patient is happy with the amount of control that they have over the disease symptoms is something that we all aspire to do as physicians. From a perspective, I'll answer your first question about access to clinical trials and then get to the other aspect of access to therapies as well. I agree with you. I 100% agree with you that we need to continue to democratize access to our clinical trials and continue to spread the word. And I think things such as what we're doing today in terms of outreach to the patient population and outreach to the patient advocates, getting together with the MDA and MGFA to spread the word and awareness about all of the activities that are ongoing in the research space. That's paramount in terms of providing information uh, to MG patients. I also think that that's an aspect of health equity and access to some of these clinical trials, and not just being restricted to centers of excellence, but going out there and being able to provide access to clinical trials in settings where folks may not know enough about what is required. And I think we continue to train sites, provide access to sites for understanding how to conduct clinical trials in areas where there may be these areas may be underserved. So especially in a rare disease like MG, going to the patients and providing them that access to trials within centers where they're already seeing their physician or neuromuscular specialist, instead of having the patients come into centers of excellence, is how we perceive this. And we continue to try to expand upon access there. The other thing that I will also mention is that Alexion definitely continues to participate and involve patient organizations as well as individual patients in the design of our trials, and continue to seek input from patient advocacy organizations, patient support groups, to help us reduce the burden of studies where we can, and also to kind of take in the patient perspective when we are designing these clinical trials. I think being able to do that and being able to design clinical trials which still deliver a high quality of data, but decentralize some of these aspects of access helps grow the ecosystem and kind of recruit more. I would say just like be able to provide access to more clinical trials in different settings as such. I think the second aspect that you mentioned about, and I'll pass it along to Kathy after I make just a couple of additional points about access to existing therapies. I think we all need to continue to educate our patients about the benefits of some of these therapies and the ability to gain control over their symptoms. But we also, as a community, need to continue to educate folks about the value that these therapies provide. In terms of, you yourself mentioned in your presentation about the reduction in the hospitalizations, the reduction in work days that are missed if people are working, and the productivity increases as such. So I think that if we are able to show the difference that these therapies make to some of these sick patients and keep them from being on ventilators or keep them from being admitted to hospitals, that's sort of the value, even from a purely economical value perspective. That's something that these therapies are able to provide and should be taken into account as well. So I'll stop there and hand it over to Kathy.
Yeah, I agree. And I think just to add it on to that, Kathy, and maybe if you could speak to, obviously Sanjay is here, but there are other team members from other pharmaceutical industry. Is there any sort of plans or desires, maybe use MDA or other MG associations as a conduit, where all these different teams with incredibly smart people trying to come up with newer drugs to make a difference? Could there be a consortium of some kind where it's drug agnostic? We're just trying to make the best thing that we could do for our patients.
Exactly. I think anytime, I think we all believe that anytime we can work together and collaborate in the right ways, it is more powerful for the patients. At the end of the day, it's the patients that we want to support. I will go back to what Sanjay said about health equity, and to everybody who participated in this webinar today. They're the informed folks. They are the ones now who own that responsibility to share with other MG patients in any way they can that there are studies out there. And with all of the scientific information we've garnered over the last 3 to 5, 7 years, the slide that you showed, we are doing more studies in pediatric populations. In seronegative, we're actually doing a pure seronegative study. And there's more going on that's specific to MG patients. But COVID did us a huge favor, and it helped us understand how important telehealth is. So there are studies that have implemented some telehealth aspects, where some of your clinical visits could be done remotely if you live a long distance. But I would say most of the industry partners that I'm aware of, and Sanjay, you can correct me, we offer travel support. We offer translation support if they don't speak the language, if they need help understanding what is this clinical study going to entail. And I think it's all of us who are participating today, including the folks I can't see. I think that it's our responsibility to continue to share with the MG community. There are resources, and we need you to participate. We want to have you involved in the studies. It's a little harder to find people sometimes if they live more remotely in those, and you can't get a study site in some area. So I hope that answered your question, but it's...
Yeah, no, it did. I think there is a clear desire to identify pockets that are not well served because they're not close to a larger university by using sort of leveraging telehealth. I think I agree with you. One good thing that came out of COVID is that I can see my patients virtually up and down the whole of California. They don't have to spend many hours to come and see me. If they need my help, I can see them right away. So I think at least virtually. So that's been a remarkable advantage.
And just to answer the access to treatments. So these new treatments come out, and I would say to a company, we have a multitude of resources. And sometimes there's academic centers, and I would love for you to speak to this, Dr. Muppidi. Some of the academic centers don't automatically offer those services and say, we're going to prescribe drug X to you, and here is how you can get some more information on getting access to the therapy. And that just is an institutional, policy maybe. But all of the medications have resources available to the patients to help them navigate that insurance journey, because that's a whole nother piece of your treatment. And it adds stress to your life and financial, concerns potentially, where there shouldn't be. There's a lot of resources available.
Yeah, I mean, I would definitely echo what Kathy mentioned or suggested as well. I think all companies that have products and drugs available in this space to provide some of these support services to help the patients understand the maze a little better and help them navigate some of the requirements for these therapies. So
agreed. I want to just emphasize something that you both said, and sometimes in clinical practice, I feel like some of my patients who are seronegative are these less common subtypes, and they feel like nobody's paying attention to them. It's not true. I promise you, the field is truly interested even in the less common ones. It's that when you are developing drugs, you go to the patients with the most frequent type of antibody, and then you sort of expand to it. So I agree with both of you, sort of expanding to non-AChR, LRP4, expanding to seronegative, and trying to sort of have these drugs be available for those subgroups. It's amazing. It's an amazing time for the field. I think we have 2 more minutes, so maybe I'll give you each 1 minute. I'll reach out to you in 5 years again to see if your answer is correct. But here is the question. Where does MG treatment go in 5 years? Okay, I'm writing it down, okay? I'll go with you, Sanjay.
Sure. So to be brief, again, I think the one thing that I do foresee with all of it, we have had amazing advances in MG therapies that are available. And I definitely see MG patients being able to, I mentioned treatment optionality and that aspect of being able to select drugs based on what suits their lifestyle and what can give them a sustained efficacy over a long period of time, being able to choose drugs based on that. And the second component that I see developing further is depending on the desires of the patients and the comfort of their prescribing physicians, this ability to potentially combine different therapies as well and be able to get to the desired level of control. Maybe it's minimal symptom expression. That's what people desire. And to be able to get that, maybe not just with one single drug, but with a combination of polytherapy as such. I do foresee within the next 5 years that might be a reality. And then obviously the other exciting opportunities with cell therapies and other things that are coming on board as well.
Sure, sure. Kathy, you have the last word.
Oh, thank you. I'm excited because I'm going to go in a very different direction, but in total agreement with Sanjay and what he shared. I think that in the next 5 years, MG patients will be more empowered. They are going to see the difference they can make. Where we were with MS 10, 12, 15 years ago, people now know what MS is, and they also know that their friend with MS is not in a wheelchair, right? So I think that patients will be able to articulate to their employer, to their family, to their healthcare team, and to their insurance companies. And the people they're speaking to will be able to understand. They're going to be more aware. And that is because there's more treatment and people can see the difference. It's not just going to be, these older therapies that had a lot of side effects that caused a lot of almost as many problems as they solve. And I think that we're going to have an entirely newly empowered patient community. I hope.
Yep.
I hope with a lot more options because there's so much research going on and it's very exciting.
Yeah, and I really do hope that both your visions are at the minimum should be true, and I'm hopeful that there would be even therapies which we can start talking about remission. We're talking about sort of resolution of symptoms on a sort of a permanent basis for prolonged periods of time. So I think with that, I want to thank MDA for allowing me to talk. Thank you both Kathy and Sanjay for jumping on and having this conversation. Thank you so much. I will pass it back on to. Thank you so much.
Great.
Well, let me put in a plug for Claire. Claire is my colleague at work, and I cherish her time with my patients. And so if you're thinking about stepping off, please don't. I'll let you go, Claire. Thank you so much.
Yes, thank you so much to our Drug Development Roundtable participants. We truly appreciate that great insight.